but nurses form the largest part of the workforce, and what we thought, as it was leading up to International Nurses Day, that we would have a particular focus. So apologies to the midwifery, health visitors and other staff groups in the audience, but I'm going to take artistic license as a nurse and talk about nursing. And what I thought I'd do is just tell you a little bit about how nursing has evolved over the years, and then focus on a couple of areas. Now I know that there are a number of nurses in the audience, so I want to use your brains and expertise, and please chip in with some examples, because some of the things I'll say will be familiar and some of the things you'll know as well. If you get the opportunity, also have a look at the board over there. We've been having some tea parties on each of our sites, and we've got some wonderful pictures of some of our nurses across the trust, and they've also been telling some stories about when they trained and about why they came into nursing. And as I go through, what you will hear that some of it sounds very familiar, some of it is coming back, and some of it is slightly different. Now, when you think about famous nurses, bizarrely, two people come up. So the first one is Florence Nightingale, who you all know very much, and then the next person that people talk about is the matron. Now, I hate to tell you, but Hattie Jakes wasn't a real nurse, but many of her qualities and the message and the model that she espoused, it resonates very well with lots of people, and we'll come back to the matrons and about important role. And although Florence was born well before the NHS, it's probably worth just reflecting in terms of how important she was to nursing and to hospital life. She made a huge impact, and many of the things that she did and she put in place are still alive today. Maybe in a different form, but she was somebody who was meticulous about record keeping. She thought a lot about public health and about epidemiology. She created the first hospital, the nurse. She created the first hospital pharmacy, laundry, and that whole thing about working, but also about what works efficiently. And even in those days, there were pressures around money and cost, and she worked hard to reduce the length of stay of patients and also the cost of the patient per day. She was fastidious about standards, what things looked like, and she was also very, very pro-education and set up education for nurses for the future. So we've got lots to be thankful about from Florence, and her role and what she was doing lives on for many of us through everything that we do. And that's not just about nursing, but about the way the whole of hospital life works. So one of the things that's always asked is about whether nursing is an art or a science. And you will all have a view about that. What was interesting is that Florence was really clear that nursing was an art. But what was interesting about Florence was that although she thought that nursing was an art, she was very scientific in terms of her approach, in terms of how she did things. And I think many people will think that actually it's an innate ability to have some of those caring, compassionate qualities. And maybe later it would be really interesting to know whether you think nursing is an art or a science. I seem to remember one of my interview questions when I came to Basingstoke Hospital in 1991, not in 2000, was that very question.
Before you were chief nurse.
That's right, that's right. So throughout the years, and some of you will remember some of these organisations, on the left-hand side is something called the General Nursing Council. And I think some of you were actually registered through the General Nursing Council. Although the Royal College of Nursing wasn't a regulatory body, actually pre-NHS and in the early part of the NHS, it had quite an influential impact in terms of thinking about nursing and what it did, and probably maybe more similar to how the BMA operates now in terms of influencing policy and things like that. And then we moved into the Nursing and Midwifery Council, which is a current regulator, and we have a code of conduct. for all nurses, which we abide by, and you'll hear some more about that shortly. So some key dates, and I'm not going to go through all of these, but this is where we start seeing that things probably haven't fundamentally changed. So at the inception of the NHS, it may surprise you or not that we didn't have enough nurses. And in fact there was a big government drive to go to the Commonwealth to get some nurses, and I think at that time we were looking for 48,000 nurses into the NHS. And many of those nurses were from the Caribbean, and they had to get authorisation from their parents to sign their passport form to come over. And there's a story about one of the Caribbean nurses who wanted to come over. Her parents didn't want her to become a nurse, they wanted her to become a teacher. So she told her father that she was going to go on holiday to America to visit one of her friends. But after stopping off at America, she then came to the UK to become a nurse. They weren't very impressed, but eventually she settled in the UK. And there are lots of fantastic stories, and I think you've all heard about the Windrush and about a whole range of people who came to support the public sector in many of those years. And I would say that for nursing, we have a very diverse workforce. We've worked in a diverse population and community for many, many years, and we're all the better for it. We have an enriched service and some fantastic colleagues, which we're very grateful and continue to be grateful for our overseas nurses who come and join us, and we'll be receiving some overseas nurses later this month from the UAE who probably started off in the Philippines. The male nurses didn't arrive until 1951, and then even back in the 50s we were continuing to report on nursing shortages and also lack of equipment. So you can see there's a bit of a trend here that it tends to sort of to carry on. There were various reports that happened over the years in terms of nursing, but I think what happened, one of the things that was most significant was in the 60s, and there was something called the Salmon Report, which recognised that nursing was actually very important and could contribute to the wider agenda of how hospitals run particularly, and recognised that there should be nursing should be part of the senior management team, and so it then followed on that nurses became part of that. Something called the UKCC, which was a regulatory body at the time, registered enrolled nurses and registered nurses. So some of you will be familiar that we had nursing auxiliaries, enrolled nurses, which were seen as a more practical training for 2 years, and then the registered nurses. Now what was interesting about the nurses who came from the Commonwealth, despite them having the right qualifications, they were generally put into enrolled nurse positions. And it was very difficult for them to then get into registered nurse positions. So there was a big review, and it was decided that we should have a new register, and that would focus, rather than having general nurses who would do lots of things, that we would focus, and there would be 4 parts of the register: mental health, learning disabilities, adults and children. And it stayed like that for some time. And then in 1986, there was then again much discussion and much debate about moving over to a diploma type nursing and moving the traditional training for nurses away from the hospitals into colleges and universities. That was the end of the enrolled nurse training, and had some subsequent consequences in terms of shortages of nursing and a whole range of other things, which I'm sure we might talk about later. Clinical nurse specialists, interestingly, didn't come in until 1975, and we have many nurse specialists. We'll talk about those later too. In 2002, nurses started being able to prescribe medication. And that was the start of advanced practice, which has become very important for us today. In terms of research, nursing research hit the stage and worldwide in the 2000s, and then in 2009, again, a change from diploma level nursing into registered nursing. And in 2015, so most recently, we've now started formal revalidation for nursing through the NOC. So in some ways, not a lot. In other ways, and of course, what's not in there are all the other changes that have happened in medical technology and the changes to the workforce. But really interesting that some of the challenges we have today in terms of our workforce and the changes in terms of training, as we go on later on, you'll see that some of this is coming back, and we may see that some of the things that we started off with are developing in another form. I thought this was interesting in terms of the salaries. What was interesting was that in the early days, the male staff got paid more than females.
Yeah.
Ooh, really? Yeah.
Yes.
Right. Fascinating. Really fascinating. And again, throughout those 70 years, there's been much debate about the pay of nurses and whether it's enough or not enough. We talked about the training earlier in terms of it was hospital based and it was very practical. So you can see there on the left hand side here, training in something called PTS, which some of you are nodding about. So you'd have 6 weeks of training in the classroom, normally practice on each other. I remember kindly putting my hand up to have a nasogastric tube put in. I don't know why I did that. It wasn't very pleasant, and I realised I was crying and it wouldn't go up, and eventually she just said, "Oh, come on, let me do it." And then they realised I had a deviated septum and it was never going to go up there. So I always had great sympathy with my patients from doing that. So lots of practical training and lots of rituals as well. So here you can see that nurses singing for their patients on a Sunday afternoon. And one of the other things which some of you also remember is about having to live in the nurse's home and being locked in and having to have a special pass after 9 o'clock in the evening. And if you came back later than that, woe betide you. Also, you would have to get a special dispensation, or you'd have to go and see the night sister. And thinking about Hattie, some of those characteristics might come into the fore when you think about the night sisters who were on duty. And many of you have watched Call the Midwife, and there was lots of work that happened out in the community. By the time that Project 2000 came in, it was probably quite contentious, it would be fair to say. And people were really worried about the fact that these nurses were going to be academic rather than practical, and they would lose those caring skills. And there was a big campaign going on, which was talked about too posh to wash, because people heard about these nurses who weren't interested in looking after the basics of patient care, but more interested in terms of the academics. And one of the things we're doing at the moment, we're having some tea parties, and we're trying to get a range of views from nurses who've worked across each of the decades since the NHS was formed. And one of the questions we're asking people is, why did you choose to become a nurse? And I think, because I speak to all the newly qualified nurses and all the students who come through now, I don't think it's fundamentally changed. I think people still come into nursing because they care and they want to make a difference, and that's still fundamentally part of what they want to do. You'll all have a view about whether the new training is right. We always hark back to why we think our training is better than anyone else's. But I think in terms of the advances in medical technology, the challenges we've got with our workforce, the complexities of our patient, we absolutely, and as patients, you absolutely want your nursing staff and other professional people to be on the top of their game. And have the highest standards and education and training possible without losing that care and compassion. So number of nurses employed, again, really interesting in terms of what we started off with and how many people are on the register now. Huge differences in terms of where we were. And I was talking to one of our clinical matrons in Winchester today, and she was just saying in her one ward we have 22 different nationalities of nurses who are working, providing great care for our patients. And I think in the hospital, or where was I reading this? I think there are something like, there are hundreds of different nationalities who all really work as part of the team to make a difference. And there's a little bit there in the 1970s, just to give you a bit about Basingstoke Hospital. So 171 nurses, planned to reach 680 by 1973. We now have 2,000 nurses working in our hospitals, which is amazing. So one of the things that hasn't changed in all of the years of nursing is around pressure ulcers and trying to prevent skin damage to our patients. And over the years, there have been a whole myriad of treatments. And I'm going to ask some of our colleagues to shout some of those out. So you can see the nurses there preparing a whole range of concoctions. And if you think about some of the length of stay many years ago, so today patients who have a hip replacement might be in for a maximum of 3 days. Many of our cases are day cases rather than be on complete bed rest. I had a disc repaired on my back a few years ago. I was up the same day and out 2 days later. Before, you would be lying on bed rest for weeks and months on end. So we did some nasty things to patients. You can see there leeches, although we still use leeches for some wound care. This is chlorhexidine and betadine, and we used to pour that into the wounds. Probably not a good idea these days. Egg white and oxygen, yes. Methylated spirits and talcum powder, and then we used to have some spray-on wounds and Opside. It's really interesting because there are a whole range of products that you use, and we did it with the best intent. Now, they probably weren't the best products to use, and sometimes, and now with our knowledge about skin and about the properties of healing, we probably wouldn't do that now. But there was something about the rigour and the standards in which it was done. So many of you will know of something called a background, and there was a trolley with a whole range of these medicines and procedures. But what we would religiously do is go around and we would ask the patients to turn over, and we would rub their arms with the appropriate liquids or creams. We would rub their elbows, their bottom and their heels. And whilst the products might not necessarily have been the right things to do, I think the fact of actually turning the patients over and on a regular basis relieving them of that pressure probably was the thing that made the difference. Of course, we didn't know that at the time. So in the 1960s, there was something called the Norton score, and that was the way we started to risk assess some of our patients and start to say who is at the greater risk of receiving pressure damage. And it wasn't until the 80s that that was then developed, and there were several other scoring systems. The most popular one, which many of you will recognise, is something called the Waterloo score, which just became a little bit more sophisticated in trying to recognise who was likely to have risk of pressure damage. And there were various others for patients who were in ITU. There was something called the Douglas score, and then we move into the latest one that we're using, which is the Braden score. Things have become much more sophisticated. So we moved from putting gauze and damaging skin by it drying out and then pulling all the heel bits of the wound away into using alginate dressings, then hydrocolloid dressings. And we're becoming much more sophisticated in terms of understanding the physiology and the healing properties of skin. And so our claim to fame in Hampshire hospitals is this one, where our microbiologists are now using something called Surgery honey, And we know that the properties of honey and its healing really make a big difference in terms of wound healing and support. And then these ones, and things looking into the future, are skin substitutes and bioengineered skin. So we're really, pushing the boundaries and making big differences. So hopefully the fundamentals of relieving pressure areas and skin damage haven't changed. It still requires attention, it still requires risk assessment, but some of the products that we can use now are really helping us, and we hopefully, who knows, in a few years' time, I hope that we'll be in a position where actually we won't be reporting in terms of pressure damage. It can be so painful, so debilitating, and those of you who have seen serious pressure damage, right to the bone and requiring plastic surgery, it's absolutely awful. I did refrain from putting any horrible pictures here, because I thought I might be going home to dinner later.
Thank you.
The other thing that's changed is around lifting and handling. So, and just on the left-hand side there, you can see the old-fashioned Nightingale wards. These have many benefits, of course, in terms of being able to see people, in terms of patients feeling reassured because they can contact somebody quickly. But over the years, we've moved away from that kind of approach for infection control reasons. It has its advantages and disadvantages. I'm not necessarily advocating we should go back to that, but there's something about recognising why that's important. The other thing that struck me as well that's changed, and some of you may or may not know this, but in the 80s, crowd immunity was lifted from hospitals. What was really important about that is that hospitals were protected to a certain extent under the Crown. So we're never required to, would never be called up for negligence or standards around hygiene. And so again, many of you have worked, and certainly I've worked during my training, where you would see cockroaches in the ward areas, really poor hygiene compliance and all those kind of things. And it's hard to imagine that now, that we wouldn't be fulfilling some of those basic standards. And so one of the other things that we've developed, both in terms of protecting our staff but also our patients, and here you can see some old-fashioned nurses really lifting the patients with their belts on, trying to protect their hats as well. Then we got, we realised that didn't work, so we had this fantastic lift called the Australian lift. It was going to protect our backs, so put our shoulders in and lift the patients up and stop them shearing from up the bed and damaging their skin. Of course, it's so much more sophisticated now, and we have fantastic beds and mattresses. We have all sorts of instruments to help support our patients, but also support our staff. And you can see a range of hoists. This is something called a hover jack. So if a patient falls on the floor, what this does is it literally, it's flat, and then it builds up and up and up. So you blow it up. So eventually you can then slide the patient across onto the bed. It's a fantastic, really simple but fantastic device. Much better for our patients in terms of protecting them, but also great for our staff too. And again, a look into the future. This is something happening in Japan at the moment, and it's a robot that will lift a patient from bed to chair, and maybe eventually prevent having to use human beings to do any lifting at all. We can have a debate about whether that's right. So, where are we in 2018? The matrons have come back, and I'm very pleased to see we've got some of our clinical matrons in the audience here. And in terms of the training, what's happening is that there's a recognition that there aren't enough nurses again in the NHS, and that we're losing something in terms of how we do things. There are huge challenges, as Alex said, but nationally and locally in terms of funding, and training funds are really challenging. But we've got some great opportunities coming up. So the first thing I would like to let you know about is we introduced 2 years ago the concept of clinical matrons. And again, this may sound vaguely familiar, but this is about getting senior clinical experts back to the bed space and being hands-on with our patients. Over the years, what's happened, unlike medicine and some of our AHP colleagues, nurses have drifted into being more managerial. In order to progress, they've had to move into management, into education, or into specialist nursing. And the majority of our patients are in our general wards. And so what we've done is we've recreated the matron role, but we've specifically called it the clinical matron role. And our clinical matrons work 80% clinically, and they're working to an advanced practice level. And that's really, really important. What's also happening nationally, this is George, who is one of our apprentice nurses. And so nationally, we're one of the pilots for nurse associates, apprentice nurses, and degree apprenticeship nurses. And this is a bit going back to training in your hospital, and also having some really grounded experience. I know that Sarah was talking earlier on today about her real grounding before she started her nurse training was when she worked as a healthcare assistant in a nursing home or St. John's Hospital.
I don't can remember the old drums that used to be in Junction Break.
Yeah. And it's really important to get that grounding before you then go on in terms of getting some of the academic. And we've been working really closely with the Open University for many years. And so some of our healthcare assistants are hugely experienced, got life experience as well, but may not have the qualifications, and we've been supporting them to get their nursing degree in a different way, but working alongside in our wards, and that's been really valuable. We want to continue to do that. We have some amazing nurses in Hampshire hospitals, and this is an example of nurses working to advanced practice level. So nurse endoscopists, nurses doing biopsies, nurses giving results. We have a whole range of nurses working at a different level. Many of our nurses now, it's routine to be able to cannulate, to do history taking, prescribe medication. And that's not taking away the fundamentals of nursing care. It's about supporting our patients in a different way. And it's really exciting because a nurse doing some of those things will probably do that in a slightly different way from some of our other professional colleagues. And we're really seeing a difference, and it's really supporting. What's important to that is about training and development, and it becomes more and more important that both our nurses feel safe, but actually our patients are getting a great deal. And that's why our clinical matrons are really, really important. And I think that's the way forward for the future. We're one of the first hospitals in the country to do this, and I think that many more will follow. The early views are that we're really seeing a difference in terms of consistency of care, but a reduction in terms of complaints, a reduction in terms of incidents, and it's really exciting because what we're doing is bringing nursing back to the bedside, which I feel really passionate about and really believe that that's the way forward. So, before we get on to questions, one thing that hasn't changed is that I'm really proud to be a nurse, and it's a real privilege to be at the best and the worst time of people's lives. And as the slides is there, nurses are there at the beginning, they're there at the end, and they're with people at their most vulnerable time. And it's a huge privilege to be like that. Nurses are really important, and you're really lucky because you've got some amazing nurses caring and looking after you and your family every single day.